there's an area that's very, very important, not only for the boards but in our practice, and that's the management of the cardiac patient for non-cardiac surgery. In the past, we had only an online version of this, but we found out there were so many questions that this year Michael's actually going to give a full lecture overview on how you evaluate and manage these patients with cardiac disease for non-cardiac surgery. So let's first start with the questions. We've got question number one is, which of the following patients is the best candidate for a preoperative stress imaging test prior to non-cardiac surgery? So we've got a sedentary 65-year-old man with diabetes, hypertension, prior TIA, iliofem bypass, claudication, but no symptoms. We've got an 88-year-old woman with diabetes, hypertension, osteoarthritis, creatinine of 1.5, scheduled for a carotid endarterectomy with a 90% left carotid disease, which you heard from Peter Pollack about yesterday. She uses a walker for mobility and reports no cardiopulmonary symptoms. A 72-year-old man with a prior MI and insulin-dependent diabetes who's scheduled for a left total hip. Despite his hip discomfort, he swims a mile 4 days a week without symptoms. You've got a 68-year-old woman who's asymptomatic, scheduled for a AAA repair. Former smoker, walks 18 holes of golf once a week. Also helps her husband rake leaves and tend their garden. So in which of these patients would you order a preoperative stress imaging test? All right, let's go to the next question. A 74-year-old woman presents with symptomatic cholelithiasis due to an impacted stone at the gallbladder neck. So she's going to need a laparoscopic and possibly an open surgery. She climbs 2 flights of stairs without impairment, has no cardiopulmonary symptoms. However, you actually take out your stethoscope, you examine her, and there's a 3/6 harsh systolic ejection murmur. The echo shows severe aortic stenosis with a gradient of 45 and EF of 60%. What is the next step? You want to proceed with cholecystectomy. Tell the anesthesiologist to watch her closely. You want to delay the cholecystectomy, do an aortic valve replacement first by a surgeon. You want to delay it and do a TAVR. You want to perform a balloon aortic valvuloplasty followed by cholecystectomy, or you want to put her on an exercise test. Which one of these would you do? This is not uncommon. We get about one of these a week, actually. Okay, 73. Final. 85-year-old woman scheduled for a left total hip, permanent atrial fibrillation, treated hypertension, no prior stroke, thromboembolism, or heart failure. She received bridging anticoagulation prior to her first THA and tolerated it well. INR is 2.5, creatinine is 0.7. What is the appropriate approach to the preoperative anticoagulation before the hip replacement? Continue warfarin and just bring the INR down. Stop warfarin 5 days prior without any bridging. Stop at 5 days prior and start low molecular weight heparin when the INR falls. Start 7 days prior. Start low molecular weight heparin when the INR falls less than 2. So this is a woman who's got atrial fibrillation, on warfarin, treated hypertension, left THA. So what would you do prior to her management, prior to her operation? Okay, Michael.
All right. All right. Well, thank you, everyone. It is a pleasure to be here. I'd like to thank Dr. Nishimura and Dr. Amon again for the opportunity to speak with you on cardiac disease and non-cardiac surgery. I have no financial disclosures to report. We have 3 learning objectives for the next 35 minutes. First, we will identify and manage patients with known or suspected coronary disease or other cardiac diseases who are at risk of cardiac complications during non-cardiac surgery. Secondly, we will identify appropriate non-invasive tests in patients with known or suspected coronary disease who are at risk of cardiac complications during non-cardiac surgery. And third, we will learn to select and adjust perioperative medical therapies to reduce the risk of cardiac complications during non-cardiac surgery, including anticoagulating agents. We're going to approach the learning objectives with the following outline. We're going to begin by talking about an approach to risk assessment prior to non-cardiac surgery. We will then move to a discussion of non-invasive testing. We will then talk about non-ischemic heart disease. This is going to include things like valvular heart disease, heart failure, and cardiac arrhythmias in patients undergoing non-cardiac surgery. And we will close with a discussion of perioperative medical therapy. Let's start by talking about risk assessment. When you are assessing a patient's risk for cardiac complications prior to non-cardiac surgery, it is very important to take a stepwise approach. And the ACC/AHA guidelines outline a very succinct algorithm that we're going to review here. The first question that you need to ask is, does the patient need emergent surgery? If the answer to that is yes, it's easy. You're done. The patient needs their operation. They don't need your preoperative cardiovascular exam. If they don't need emergent surgery, the next question is, are they having an acute coronary syndrome? If the answer to that is yes, then treat the acute coronary syndrome, and we're going to learn all about that from our colleagues this afternoon. If the answer to that question is no, then you need to calculate the combined clinical and surgical risk, and this is a 2-component risk assessment. There's a clinical component and a surgical component. To calculate the clinical risk, the guidelines recommend using one of these online calculators, which comes from the NSQIP database. These calculators are great because you can access them in your office, plug in a bunch of patient variables, get a risk printout that you can share with the patient and use to make decisions. They are less helpful for the boards because the boards aren't going to let you pull up Google. Okay? So what do you need to know for boards? For the board's purposes, it is still very important to understand the revised cardiac risk index. This has been around for a long time. This cardiac index is still very important when it comes to predicting a patient's clinical risk prior to non-cardiac surgery. And it outlines 5 risk factors. Number 1, is there a history of coronary artery disease? Number 2, is there a history of congestive heart failure? Number 3, is the creatinine over 2? Number 4, has the patient had a prior stroke or TIA? And number 5, does the patient have insulin-dependent diabetes mellitus? If the patient has at least 2 of their predictors, you can consider them at higher risk. Now that's the patient's clinical risk that the patient walks around with independent of their surgery. The next step is to look at their surgical risk. This is data from over 10 million hospitalizations. It was just published in JAMA Cardiology earlier this year. And this data, which is relatively recent, 2004 to 2013, identified a few different surgical types where cardiac event rates in the setting of non-cardiac surgery were over 5%. Those surgical types were vascular surgery, thoracic surgery, and transplantations. So if a patient is undergoing one of these operations, you can consider them undergoing a high-risk procedure. On the other end of the spectrum, we have low and intermediate risk operations. This table comes from the European Society of Cardiology's guidelines on non-cardiac surgery. You don't need to memorize the whole table. I place it here to highlight a few specific surgical types that you should consider low risk. Breast operations are considered low risk, even mastectomies. Eye operations are considered low risk. And asymptomatic carotid endarterectomies or carotid artery stenting, as Dr. Pollack discussed yesterday, are also considered low risk, with a rate of perioperative complications less than 1%. So we calculate a patient's combined clinical and surgical risk, and if that is less than 1%, then you have a class 1 indication to move to the operating room. And I want to make an aside point that for the rest of the talk, if you see a green arrow or box, that's a class 1 recommendation. If you see a yellow arrow or box, that's a class 2A recommendation. If you see an orange arrow or box, that's a 2B recommendation. And if you see a red arrow or box, that's a class 3 recommendation. So I've used that color coding scheme from this point forward. So if they have low risk, you send them to the operating room. If their risk is 1% or greater, and that can come from the clinical side or the surgical side, then you need to estimate their functional status. How do you estimate a patient's functional status? You want to start by asking 3 questions. First of all, can you climb 2 flights of stairs? Secondly, can you walk 4 blocks on level ground? And third, can you rake leaves or push a lawnmower? If the answer to those questions is yes, then the patient can perform over 4 METs of activity. If the answer to those questions is no, or I don't know, then you have to assume that the patient is going to be able to perform 4 METs or less. And that 4 MET threshold is going to be important, as we're going to see in a little bit. Another way to look at functional capacity is this paradigm. If a patient can do basic activities of daily living, eating, dressing, using the toilet, that's about 1 or 2 METs. Walking around the house, walking on level ground is about 3 to 4 METs. As we just discussed, climbing up 2 flights of stairs or walking up a hill is 4 to 5 METs. Sexual intercourse actually falls in this category as well. Doing things like heavier work around the house, like scrubbing floors, moving furniture in that 7 to 8 MET range. And then there's a group of activities that fall into the 10 MET range, suggesting very good functional capacity. So these are things like swimming, singles tennis, skiing, or playing basketball. If a patient can participate in these athletic activities, they have an excellent functional capacity. Why is that important? Well, if they have a functional capacity over 10 METs, they have a class 2A recommendation to move forward to the operating room without any further testing. If they're in that 4 to 10 MET range, it's a 2B recommendation to move to the operating room without further testing. And if they're less than 4 METs, or you can't determine their functional capacity, that's when you have to determine the need for further testing. And the first question you have to ask yourself is, will further testing impact decision-making or perioperative care? If the answer to that question is no, then it doesn't matter whether you get a stress test or not, you send the patient to the operating room. If the answer to that question is yes, then you have a class 2A recommendation to move forward with a pharmacological stress test. And that is a very nice segue into the next portion of our talk on non-invasive testing. Let's take a step back for a moment and talk about perioperative cardiac events. They can be caused by any number of things. They can be caused by catecholamine surges at the time of the operation, the prothrombotic milieu that non-cardiac surgery may induce, blood loss, volume shifts, coronary plaque destabilization, and then fixed coronary artery stenoses causing supply and demand mismatch. And when we think about stress testing prior to non-cardiac surgery, stress testing will only help us predict the impact of these fixed coronary artery stenoses. A lot of these other factors are much less predictable. That being said, over the course of the last 10, 20 years, even more, we have a robust literature on the role of stress testing prior to non-cardiac surgery. I'm going to try to summarize that with 5 points on this slide. First of all, preoperative stress testing has a high negative predictive value. If you have a negative test, your likelihood of perioperative cardiac events is very low. Secondly, it has a low positive predictive value. So even if you have a positive stress test, that does not necessarily convey a high risk of perioperative events. Number three, resting abnormalities matter. What does that mean? That means if you have fixed perfusion defects on nuclear imaging stress tests or fixed wall motion abnormalities on stress echocardiograms, that still conveys a higher risk independent of the amount of ischemia. Number four, ischemia matters. We've already talked about this a little bit in terms of the chronic coronary disease, but more ischemia on stress testing is going to increase your risk of postoperative events. And number five, the higher risk patients, the more accurate the test. You're going to have a better negative and predictive value in the patients that are more likely to have events that are patients that are going to be at higher risk. So with that in mind, with this paradigm in mind, what do the guidelines say about stress testing? We'll first talk about pharmacological stress testing prior to non-cardiac surgery. The American guidelines recommend avoiding routine use in low-risk patients prior to non-cardiac surgery. That's sort of intuitive. You don't want to do a stress test on everyone. They say it is reasonable, as a Class 2A indication, reasonable in patients at elevated risk with poor functional capacity if it will change management. If we look at exercise testing, the guidelines say that you could forego testing in patients with an elevated risk if they have excellent functional capacity. As with pharmacological stress testing, they say you should avoid it routinely, particularly in low-risk patients. And then the guidelines outline a number of Class 2B recommendations. You could consider functional testing in patients with elevated risk and unknown functional capacity. You could forego exercise testing in patients with elevated risk and moderate or good functional capacity. Or you could consider exercise imaging stress tests in higher risk patients with poor or unknown functional capacity. I read this and I was confused. Is anyone confused when they read that? So what did I do in this situation? Well, I looked actually across the pond to Europe, and I think the European guidelines do a relatively good job of succinctly defining the population of patients where we should be considering non-invasive stress testing. They were published around the same time as the ACC/AHA guidelines, and they give a Class 1 indication to patients undergoing non-cardiac surgery if the following three conditions are met. Number one, is the surgery high risk? These are going to be things like your peripheral vascular operations or your abdominal aortic aneurysm interventions. Number two, does the patient have at least 2 clinical risk factors, as we talked about with our revised cardiac risk index? Number three, does the patient have poor functional capacity? If all three of those factors are met, then the patient has a Class 1 indication for stress testing prior to non-cardiac surgery if the stress test will change management. The European guidelines also give a 2B recommendation. You could consider stress testing prior to intermediate or high-risk surgery if you can do less than 4 METs and you have 1 or 2 clinical risk factors. And as with the American guidelines, you should avoid stress testing prior to low-risk surgery. Okay, that's good. That makes things a little bit more clear. But now, what do you do if the stress test is positive? Okay, it's nice, it's easy if you get the stress test and it's negative. What do you do if the stress test is positive? This is a complex topic, and each decision needs to be individualized. It's beyond the scope of this talk to go into the degrees of abnormalities in stress tests, but that's very important. My colleague Rob McCulley has a very nice online lecture in the Learning Portal about risk stratification and stress testing. If you look at that, you can see sort of what constitutes a low, intermediate, and high-risk stress test. But the bottom line is that you want to treat a positive stress test in the preoperative setting like you would any other positive stress test. Just because they're going to the operating room for their non-cardiac surgery doesn't mean that you need to treat that positive stress test significantly differently. What about other preoperative tests? You should avoid doing an ECG in low-risk asymptomatic patients, but it is reasonable to do an ECG in patients with known heart disease unless they're undergoing low-risk surgery. You could also consider doing an ECG in asymptomatic patients, again, unless they are undergoing low-risk surgery. Resting LV function assessment, typically done with resting transthoracic echocardiography. Again, you want to avoid doing it routinely, but it is reasonable in patients with heart failure, particularly if there is a change in their clinical status. It is reasonable in patients with undiagnosed dyspnea, and you could consider reassessment of LV function in patients that have had difficulties with heart failure previously, but are now clinically stable. Cardiopulmonary exercise testing can be considered for elevated risk procedures. I think this is particularly helpful if you're trying to sort out exactly where a patient's functional status may fall. Who needs a preoperative coronary angiogram? This question comes up not infrequently. The answer is it's the same as who needs a coronary angiogram independent of the non-cardiac surgery. So if a patient has unstable symptoms, you're obviously going to take them to the cath lab. If they have a high-risk stress test, you're going to take them to the cath lab. Or if you are concerned about severe coronary disease with or without left ventricular function, left ventricular dysfunction, those are the patients that need to go to the cath lab. So I've covered a lot of material about non-invasive testing. What's the bottom line? If you remember these 2 points, it will serve you well for both your boards and your clinical practice. First of all, obtain an imaging stress test in patients with multiple risk factors undergoing high-risk surgery and poor or unknown functional capacity if it will change your management around the time of the operation. And number 2, obtain an ECG, resting echo, cardiopulmonary exercise test, and or coronary angiogram if you otherwise would do so independent of the non-cardiac surgery. If you remember these 2 points, you will be well served for your boards and your practice. So let's recap risk assessment now that we've covered everything, including non-invasive stress testing. Remember, first question that you need to ask, is the surgery emergent? If it is, patient goes to the operating room, you're done. Number 2, is the patient having an acute coronary syndrome? If the answer is yes, treat their acute coronary syndrome. Number 3, calculate their combined clinical and surgical risk. If that is less than 1%, send the patient to the operating room. If that is more than 1%, assess their functional status. If their functional status is good, send them to the operating room. If their functional status is not good, then you can consider, but you are not obligated to perform, but you could consider non-invasive stress testing if it will change management. We've covered now risk assessment, we've covered non-invasive testing. Let's move to non-ischemic heart disease. So when I was putting this talk together, I dug through the archives and found this paper from the New England Journal of Medicine in October 20th, 1977. How many people remember what they were doing in October? How many people were alive in October 1977? So this is an old paper, but it was one of the first papers identifying specific risk predictors prior to non-cardiac surgery. And this paper actually found that patients with severe aortic stenosis undergoing non-cardiac surgery had a 13% perioperative mortality. 13% perioperative mortality. That got a lot of people scared, and over the next several decades, there was a lot of angst about taking patients with significant valve disease to non-cardiac surgery. However, over the next several decades, anesthesia techniques evolved, surgical techniques evolved, and we started to understand that maybe it's not as bad as we thought. This is a paper published in the late 1980s from here at Mayo Clinic looking at 48 patients with aortic stenosis undergoing non-cardiac surgery. These patients had a mean valve area of 0.6. 0.6, that's pretty bad aortic stenosis. And still, with close intraoperative and perioperative hemodynamic monitoring with trained anesthesiologists that would keep a very close eye on these patients, we were able to get them through their non-cardiac surgery with no intraoperative deaths. What we started to understand is that, yes, significant valve disease, particularly severe aortic stenosis, will increase your risk, but over time, outcomes have improved, and the guidelines have recognized this And they now say that elective non-cardiac surgery with appropriate intraoperative and hemodynamic monitoring is reasonable to perform in patients with asymptomatic severe aortic stenosis. You need an anesthesiologist who is very comfortable handling the hemodynamics associated with aortic stenosis. You need to have their medical therapy optimized going into the operation, but it is reasonable to take these patients to their non-cardiac surgery. And you can consider elective non-cardiac surgery in patients with asymptomatic severe mitral stenosis if the valve morphology is not amenable to percutaneous balloon mitral valvotomy. We're going to talk more about interventions for aortic and mitral stenosis on Tuesday, but if you understand this for the purposes of your preoperative evaluation, that will be very helpful. I want to make one point that the guidelines do not, I want to make one point that there is no role for prophylactic balloon aortic valvuloplasty prior to non-cardiac surgery. You don't want to go ballooning or aortic valves open just to get the patient through their non-cardiac surgery, because then the valve is going to restenose in a few weeks and the patient could be worse off than they were when they started. So you don't want to go ballooning aortic valves before non-cardiac surgery. If we think about regurgitant lesions, those are actually better tolerated than stenotic lesions. They are typically a volume load on the left ventricle rather than an isolated pressure overload situation as we see with aortic stenosis. And if you can maintain a patient's preload and avoid excessive afterload, these patients often do quite well. So guidelines say that as a two-way indication, elective non-cardiac surgery is reasonable in patients with asymptomatic severe mitral regurgitation and aortic regurgitation, particularly if the left ventricular ejection fraction is normal. Let's move to cardiac arrhythmias. Obviously, if a patient is having an unstable cardiac arrhythmia, you want to treat that before taking the patient to the operating room. If the patient develops postoperative cardiac arrhythmias, you want to look for other causes, hypoxia, hypercarbia, electrolyte abnormalities in these patients. And we do this every day. How often do you get called from the thoracic surgeon saying, my patient went into AFib, come cardiologist, help me? Okay, it happens all the time. Often there are reversible causes that you can manipulate to help these patients do better. If a patient is on an antiarrhythmic medication like a flecainide or a propafenone or something like that, you want to continue that throughout the perioperative period. You don't want to get them off of their antiarrhythmics. That could cause more trouble than you want to deal with. In patients with congestive heart failure, we're going to talk a lot more about this on Wednesday, but for preoperative purposes, you want to optimize their guideline-directed medical therapy. And if their heart failure is newly diagnosed, you want to delay their elective non-cardiac surgery for medication initiation and titration. If they're on beta blockers, you want to continue those beta blockers perioperatively. If they're on ACE inhibitors or angiotensin receptor blockers and they are at risk for hypotension, then you may want to hold them the day of their operation, but you want to get the patient back on it as soon as you can afterwards. That is a nice segue into the last section of our talk on perioperative medical therapy. We're going to break this down into 5 sections. First of all, we will start by talking about beta blockers. Then we will move to statins. We will then cover antiplatelet therapy, followed by anticoagulation therapy, and then a few miscellaneous medications. The story of beta blockers in the preoperative setting is a very long one. This is the DECREASE-1 study that was published in the New England Journal of Medicine in 1999, looking at 112 patients undergoing major vascular surgery who had an abnormal dobutamine stress echo, so relatively high risk. And they were randomized to bisoprolol, started 1 week preoperatively, versus standard care. The outcome was 30 days. Postoperative death, non-fatal myocardial infarction, so relatively hard outcome. And you can see on the survival, on the outcome curves here, a significant difference in event rates. So patients in the standard of care arm had a 34% event rate. Patients in the bisoprolol arm had a 3.4% event rate. Needless to say, the p-value was significant. Now, sometimes if data looks too good to be true, it might just be too good to be true. This was from Dr. Poldermans, and as many of you know, a lot of his results have come under significant question for research fraud. But there were other studies that also showed similar benefits to beta blockers in the preoperative setting. And then along comes the POISE trial. And the POISE trial was published in The Lancet in 2008, looking at a much larger group of patients, over 8,300 patients randomized to metoprolol succinate 100 milligrams, so relatively high dose, given 2 to 4 hours before going to the operating room. So these patients got their beta blocker and then went off to surgery. And you can see here that yes, the patients who got beta blockers had a lower rate of perioperative myocardial infarction, but they had higher rates of stroke, higher rates of hypotension, and higher mortality rates. And all of these were statistically significant. P-values were less than 0.01 here, and the p-value was about 0.03 in the mortality outcome. And so guidelines will say, based on the POISE trial and others like it, that you can continue beta blockers in patients taking them chronically. Okay, so if the patient is on a beta blocker, that's a class 1 indication, continue the beta blocker. You can consider starting beta blockers in high-risk patients, provided you have ample time to assess safety and tolerability. That is very important. You want to be able to see how these patients tolerate the beta blocker before sending them off to the operating room. And based on the POISE trial, you do not start beta blockers the day of the operation. You do not start high-dose beta blockers the day of the operation. You need to assess the patient's tolerability of these medications. Statins, the picture is a little bit easier. Class 1 recommendation to continue statins in patients taking them chronically. Preoperative initiation of statins is reasonable in patients undergoing vascular surgery. These patients should probably be on a statin anyway for secondary prevention. If they're having vascular surgery, they probably have atherosclerotic disease, so they should probably just be on their statin anyway. Antiplatelet therapies. How many of you have gotten a question about Plavix in the last few weeks in the perioperative setting? Okay, I just got one last week from an internist. Okay, it's not as complicated as you might think. Why? Coronary stents are getting better. As we've talked about in the last few sections on chronic coronary disease, stents now have an improved safety profile and a lower risk of stent thrombosis. And the use of bare metal stents is becoming less and less common. Furthermore, low-dose aspirin, 75 to 100 or typically 81 milligrams a day here in the US, is becoming more accepted. It has lower bleeding risks. And for these reasons, how to manage antiplatelet therapy in the perioperative setting is actually not as complicated as you might think. We have recent guidelines published in 2016 on when to hold a P2Y12 inhibitor. This is things like your clopidogrel, your prasugrel, after PCI for non-cardiac surgery. If the patient had a bare metal stent placed, you can wait 30 days, and then class 1 indication, you can stop the P2Y12 inhibitor and send the patient to the operating room. If the patient had a drug-eluting stent, and I'm going to qualify this by saying a non-first-generation drug-eluting stent, so a second or third-generation drug-eluting stent, which are the majority of drug-eluting stents placed in the US currently, 3 to 6, you can stop the P2Y12 inhibitor as soon as 3 months afterwards and send the patient to the operating room. That's a 2B indication. If you want to wait 6 months, you have a class 1 indication, you can then stop your antiplatelet therapy, or your P2Y12 inhibitor. You want to avoid holding the P2Y12 inhibitor less than 30 days after a bare metal stent and less than 3 months after a drug-eluting stent, and you want to continue aspirin throughout the perioperative period and then resume your P2Y12 inhibitor as soon as you can afterwards. To bridge or not to bridge, that is one of the final questions that we're going to be talking about here. This can be a complex topic. I'm going to try to break it down. When you are faced with a question of bridging, you want to ask yourself 4 questions. First of all, is the initial indication for long-term anticoagulation appropriate? In other words, does the patient need to be on the anticoagulation in the first place? If the answer to that is no, then you stop the anticoagulation. It's easy. Always helpful to ask that question. Number 2, can the procedure be performed on anticoagulation? If the answer to that is yes, then again, it's easy. Send the patient to the operating room. Number 3, if you need to stop the anticoagulation, when should you hold it? And number 4, if you're holding anticoagulation, do you need to cover the patient with a parenteral form of anticoagulation in the time that they are not therapeutically anticoagulated? In terms of holding anticoagulation, if the patient is on warfarin, you want to check their INR about 1 week before their operation. If their INR is between 2 and 3, you can stop their warfarin 5 days before the procedure and let it drift down. If their INR is less than 2, you stop their warfarin 3 to 4 days before the procedure, and if their INR is over 3, you want to stop it at least 5, potentially even 7 days before the procedure and let it drift down. If the patient is on a direct oral anticoagulant, then it becomes a little bit more complicated. And then there are 3 factors that will dictate when you stop their direct oral anticoagulant. First of all, what specific DOAC are we talking about? Because they all are metabolized slightly differently. Number 2, what is the patient's renal function? And number 3, what is the bleeding risk of the procedure? Talking about all of the different iterations of that is beyond the scope of this talk. I will refer you to this in-press but published online consensus statement from the American College of Cardiology. There's a very nice table in here looking at all of the different scenarios and helping you decide when to hold your direct oral anticoagulant. Importantly, because of the short half-life of these direct oral anticoagulants, bridging is rarely needed. So you rarely need to cover these patients because the anticoagulation goes away relatively quickly, and you can start it up relatively soon after the operation. I want to make one specific mention of patients undergoing neuroaxial procedures. These are things like your epidural steroid injections, your intrathecal catheter placements, your sympathetic blocks, your vertebroplasties, kyphoplasties, things like that. The proceduralists are dealing with high-stakes, high-pressure real estate, okay, high-value real estate in that situation. So you want to make sure you absolutely don't have any bleeding complications. And the anesthesiologists have released guidelines on how to handle patients on DOACs undergoing these neuroaxial procedures. And if the patient is on dabigatran, you're going to need to hold it 4 to 5 days before the procedure. If the patient is on apixaban or rivaroxaban, you're going to want to hold it 3 to 5 days before the procedure. Give it plenty of time to get out of the system so that the patient doesn't have spinal bleeding. When to bridge. So we've made the decision about when to hold our anticoagulant. Now we need to make the decision about whether to cover the patient with anticoagulation when they are subtherapeutic. This is going to largely deal with patients who are on chronic anticoagulation for atrial fibrillation. Jeff Geske, my colleague on Tuesday, is going to talk about bridging for patients with prosthetic heart valves. When you're making decisions about bridging, you want to balance the thrombotic risk against the bleeding risk, and you can assess the thrombotic risk with the CHADS-2 VAS score. If the CHADS-2 VAS score is less than or equal to 4, and the patient doesn't have a history of prior stroke or TIA, then their thrombotic risk is considered low, and you do not need to bridge. If the patient has a CHADS-2 VAS score of at least 7, or a recent stroke or TIA, then their thrombotic risk is considered high, and you want to use bridging. For the patients that fall in the middle, their CHADS-2 VAS score is 5 to 6, or they've had a remote stroke or TIA, then you want to assess their bleeding risk. And you do this by things like looking at their history. Have they had bleeding in the past when they've gotten bridging anticoagulation? What is their HADS blood score? Do they have a history of intracranial hemorrhage or GI bleeding or things like that? Are they on dual antiplatelet therapy for a recent coronary stent? If their bleeding risk is low, use bridging. If their bleeding risk is high, you do not need to use bridging. I want to make one particular caveat that when we talk about recent versus remote stroke in this context, we're going to use 3 months as the cutoff. Okay, so a recent stroke would be less than 3 months ago. Those are the patients that are going to be at higher thrombotic risk. When to resume anticoagulation? You want to restart warfarin the day of their operation. When they get out of the operating room, they start getting up from anesthesia, you put them back on their warfarin. It's going to take time to drift up. You want to start low molecular weight heparin when you achieve hemostasis. If the patient is at low bleeding risk, you want to start at 24 hours after the operation. If the patient is at high bleeding risk, you want to wait 48 to 72 hours after the operation. This is very important because a lot of the peri-procedural bleeding that we see actually comes from too early reinitiation of parenteral anticoagulation. So you don't want to start it too early. If the patient is on a direct oral anticoagulant, you start that about the same time you would start low molecular weight heparin if they were on warfarin. I want to have one quick slide on other preoperative medications before we review our perioperative medical therapy. Clonidine, there's some studies that have shown that it is potentially harmful in the preoperative setting. It's not recommended. ACE inhibitors and ARBs, as we touched on with the heart failure patients, you may continue or hold them depending on the risk for hypotension. If the patient is at risk for hypotension and you take them off their ACE or their ARB, you want to resume it as soon as you possibly can afterward. And there's no good data to recommend use of calcium channel blockers, but as we're going to learn about on Wednesday, you want to avoid diltiazem or verapamil in patients with congestive heart failure. Let's recap perioperative medical therapy. I've tossed a lot of information at you. Key point on beta blockers. If you need to initiate a beta blocker in the perioperative setting, you want to start low and you want to go slow. You don't initiate high-dose beta blockers shortly before an operation. Statins, you want to use preoperatively as you otherwise would in non-preoperative settings. Antiplatelets, you want to hold your P2Y12 inhibitor. You can hold it 30 days after a bare metal stent and 6 months after a drug-eluting stent, potentially 3 months, but 6 months would be ideal. You want to limit bridging in patients where the thrombosis risk is going to significantly exceed the bleeding risk. You want to avoid use of clonidine, and you can hold ACEs and ARBs if you need to, if there's a risk for hypotension, but you want to get the patient back on it as soon as they can afterwards. Let's summarize. We talked about risk assessment. Remember that 5-question stepwise approach. We talked about non-invasive testing focused on our highest risk patients undergoing our highest risk surgery in situations where it will change management. We talked about non-ischemic heart disease, including valvular disease, arrhythmias, and heart failure. And then we covered perioperative medical therapy. I'm going to leave you with 4 pearls for the boards. So non-invasive imaging stress tests are indicated in patients with multiple risk factors undergoing high-risk surgery with poor or unknown functional capacity if they will change management. Number 2, patients with severe asymptomatic valve disease can undergo elective non-cardiac surgery in most situations with close hemodynamic monitoring. Number 3, you want to avoid initiating high-dose beta blockers shortly before non-cardiac procedures. And number 4, you want to limit the use of bridging anticoagulation to situations where the thrombotic risk is going to significantly exceed the bleeding risk. With that, I would like to thank you for your time, and we will move on to the questions.
Okay, a lot of information here, and you can see why we made this into a formal talk, because there's new stuff all the time, new guidelines all the time, so on and so forth. All right, let's go back to this question. So which of the following patients is the best candidate for a preoperative stress imaging test prior to non-cardiac surgery? A 65-year-old guy with diabetes, hypertension, prior TIA, going for ileal-fem, has claudication. The 88-year-old woman with diabetes, hypertension, osteoarthritis, creatinine of 1.5, scheduled for carotid endarterectomy. A 72-year-old man with a prior MI, insulin-dependent diabetes, scheduled for a THA, still swims a mile 4 days a week. A 68-year-old asymptomatic woman scheduled for a AAA repair. She's a former smoker but walks 18 holes of golf and rakes leaves and tends their garden. Which of the following patients is the best candidate for a preoperative stress imaging test?
Okay.
All right. So, you know, I had like 7 questions. The guidelines are continuing to say if it will change management.
Right.
Take this, what do you mean? So take this guy, what do you mean by if it will change management?
So you'd have to ask yourself, if he has a high-risk stress test, are you willing to delay his non-cardiac operation for him to have his coronary disease taken care of? And if the answer to that is yes, then you could potentially use your stress test to, and if you identify high-risk findings, then you may have to revascularize him. Now, you could also use the stress test to potentially adjust his medical therapy. So if he is, maybe you put him in you give him some dobutamine, you take him to the echo lab, and you see, okay, you're suspecting that he becomes ischemic, but at what heart rate does he become ischemic? And if he can get up to a heart rate of 120, 130, 140 beats a minute before he gets ischemic, that's going to be lower risk than if he gets ischemic at 100 beats a minute. And so you can tell the anesthesiologist that, yeah, you need to keep this guy's heart rate here.
Well, I was told by Martin Abel, you don't tell the anesthesiologist
Oh, yeah.
about the heart rate, but
Right.
go ahead.
But you can adjust their medical therapy accordingly and sort of manage their perioperative medications based on the risk. If you think that the stress test will help you make those medication adjustments, then it's reasonable to do the stress test.
So I think the bottom line is, if you were to see this guy without surgery and felt he was at high risk, and you know that you would bypass him to improve survival, as Chet talked about, then you would go ahead and do the stress test.
Yeah.
But if you didn't think he would, if you wouldn't go ahead and bypass him before the operation, bypass him anyway, because he was frail, he had limited lifespan, he didn't have high enough risk factors, you would not do the stress
Correct.
test.
Exactly.
Okay, so I think that's what, I talked to Glenn, the guys writing the guidelines, said, what do you mean by change management? And what they mean is that if you saw this person without a non-cardiac surgery, would you still proceed with the stress test to identify what Chet talked to you about is high risk enough to warrant revascularization? And I think that's what it means and stuff. Okay, now, couple questions about the Canadian guidelines. Have you heard about those?
I can't say I'm as familiar. We've sort of focused on the European.
Yeah,
and
so
American
the
guidelines.
Canadians actually came out on top of the Europeans and said, let's remove all stress tests and only use BNP. Any thoughts on that?
Yeah, I think there is some data to say that, biomarkers could convey a higher risk. I think, your clinical risk assessment is still certainly going to matter in that situation. And if you have a patient with dyspnea, then, your BNP may sort of help you sort that out. But I don't know if in the preoperative setting, I certainly haven't been using BNP a whole lot in my practice.
Yeah, and in your practice, you would be hesitant to not do a stress test on these very, very high-risk patients.
Exactly, for the
who
reasons
can't exercise.
Exactly, for the reasons that we just talked about.
Okay, and then post-operatively, in the patient who's at a higher risk for coronary artery disease, what do you do? I mean, do you check troponins? Do you check ECGs? Do you put them in the unit? Do you have a Swan-Ganz catheter in place?
So I know that some of our patients who are undergoing, some of our higher risk patients undergoing major vascular surgery are getting troponins and ECGs. They're not necessarily getting Swans, but they are monitored very closely. And, if you, I think you can base a lot of your judgment, though, on how the patient's doing clinically. So if the patient is starting to have ECG, if the patient is having symptoms, or if they're having arrhythmias or something like that on telemetry, then that should cue you in to assess, check their biomarkers and check their ECG. I worry about sort of routinely doing biomarkers and ECGs because you're going to find a lot of nonspecific findings.
Yeah, so routine biomarkers certainly you don't want to do, or else you're going to get yourself in trouble. Right. Once-a-day ECGs in the very high-risk patient, though, might be a reasonable thing to do, just to be sure. And then there are a lot of questions on, the comment was for beta blockers.
Right.
So you got a high-risk patient. You said start slow and go up and take your time. Can you give us an example? You got this guy going for AAA therapy. Mm-hmm. You want to put him on a beta blocker. He's never been on a beta blocker before. He's got a heart rate of about 80. What would you do? So
I would probably start him, assuming he's got adequate blood pressure, I'd probably start at least 2 weeks ahead of time. I'd probably start short-acting metoprolol tartrate, low dose, so in a normal-sized male, probably 25 milligrams twice a day. And I'd want to see that resting heart rate around 60 beats a minute, because then you're getting enough beta blocker effect. And once you get to that point, and the patient is doing well, for a few days to even a week, then you can send them to the operating room. But you don't want to give really high-dose beta blocker right up front. You don't know how they're going to respond.
Yeah, so probably, I agree with Michael, a couple weeks ahead of time. Your aim is to get your resting heart rate about 60 beats per minute. So sometimes the dosage is going to vary.
Right.
But if you can get that resting heart rate 60 beats per minute for a few days before the operation, you know they're going to be well protected. Okay, so let me see. Anything else on coronary disease? Oh, yeah. What about aspirin? Do you ever stop your aspirin? You talked about stopping the clopidogrel. Do you ever stop your aspirin?
So it sort of depends on why the patient's taking aspirin and
for a stent.
For stents, so I try to avoid stopping aspirin unless I mean I have to have a long discussion with the surgeon, but no, for the most part you want to continue their aspirin.
You have to have a long, adamant discussion with the surgeon and say we're not stopping the aspirin.
Exactly.
Okay, and then the 6-month thing for stents, is that both? The guidelines say that actually the stents after an acute coronary syndrome should have dual antiplatelets for a year.
Right.
And stable angina could be 3 to 6 months.
So the way I interpreted the guidelines was that if they have to come off of their dual antiplatelet therapy and they had a recent acute coronary syndrome, you wait the 6 months, you can stop it, but then you need to get back on it and finish out your 1 year. Yeah. In the stable situation, that's when you can stop your dual antiplatelet therapy. So if they had PCI for chronic angina, you go your 6 months, you stop it, then you can be done with it. But if it's an acute situation, you go your 6 months, then you can stop it, come off it for your non-cardiac surgery, then get back on it.
But I think for all patients who've had recent stents, at 6 months, if the surgery is necessary,
correct, exactly,
we can stop the clopidogrel, but have to continue the aspirin. Mm-hmm. And if it's an acute coronary syndrome, you have to make sure they get on the clopidogrel post-op.
And the other, you can always say, well, can you wait and put off this total knee for 12 months?
Yeah.
Yeah.
So anything you can put off, you put off. And then here's a great question.
Sure.
You have a person come to you who's already had a stress test they shouldn't have had.
Yeah.
and it's positive.
Right.
What are you going to do?
Well, you do it, you treat it. I mean, we all get consults for abnormal stress tests, and you treat that just like you would independent of the non-cardiac surgery. So what's the patient's clinical risk? What are their symptoms? What's the stress test look like? How high risk is it? So a low-risk stress test with 1 to 2 segments of ischemia, oftentimes those patients, you just treat them medically, particularly if they're not having any unstable symptoms. You got the high-risk stress test where they have a lot of ischemia, their LV falls apart. You probably need to take a look at their coronaries in the cath lab, and then that intermediate risk group where they have 3, 4, 5 segments of ischemia, their LV functions may be okay. Those we don't really know, and that's where the ischemia trial is going to help us.
Okay. Let's go to the next question. 74-year-old woman presents with symptomatic cholelithiasis due to an impacted stone. Now that's important, okay, because this is telling you about the urgency of the surgery. She climbs 2 flights of stairs without impairment, has no cardiopulmonary symptoms. She's got this harsh systolic ejection murmur. Her gradient's 45, severe AS, ejection fraction 60%. What's the next appropriate step? So just go ahead with the surgery, delay the cholecystectomy, perform aortic valve replacement, delay it, perform TAVR, perform a valvuloplasty, or perform an exercise echocardiogram. Ah.
100%. I don't know if we've done that yet. Okay, next question. Let's go on.
Well, wait, you're not off the hook yet. So you're exactly right in this patient. Couple things for the anesthesiologist, though, is they get really upset if you tell them to watch the heart rate and blood pressure. But one thing they don't realize is that in patients with aortic stenosis, the major thing to do is to keep that blood pressure up. And this is where this phenylephrine that they use comes in handy, because in the AS, If the blood pressure goes down, they get ischemic, their pump goes down, they get more ischemic. It's this vicious cycle. So the one thing you can tell them is to keep the blood pressure up, and they would appreciate that. But the other question comes up is change this a little bit. Let's say the person's got an EF of, let's say, 40%, or they have some heart failure. What would you do?
So it's going to depend on a lot of different factors. So how urgent is their non-cardiac surgery? How symptomatic are they? How bad, assuming they have severe aortic stenosis, you're going to need to intervene on their valve at some point, but she's got an impacted stone. So her gallbladder is going to need to come out. And so you want to try to optimize her volume status as much as you can with your diuretics and things like that. And then you take the, you get her through her non-cardiac surgery, and then you can come back and address the valve. Because you're going to have the whole issue of anticoagulation with a fresh valve. Even if it's a bioprosthetic, we will often have to use some type of antithrombotic therapy in the early postoperative period.
Excellent. So this is clinical judgment, and what you need to understand is these people with the gallbladder disease, if you go ahead and you operate on them, in the postoperative period, they're going to develop a hot gallbladder, which is the last thing you want with a new valve in place. So with these gallbladder things, if you can get them through, like Michael says, you get them through. Alternatively, if this guy wanted just a hip replacement and had aortic stenosis with a depressed LV function, then what would you do?
Well, if it's the hip replacement's elective, that can be put off. So then you take care of the valve, and then you do the hip.
And you know the valve needs to be taken care of anyway.
Right.
So you would do it before your hip replacement. So you're absolutely correct. You have to weigh the risk of the surgery, a non-cardiac surgery, and going ahead with your optimal treatment. Okay, last question. 85-year-old woman scheduled for left THA, permanent atrial fibrillation, treated hypertension, no prior stroke or thromboembolism. Her INR is 2.5, creatinine 0.7. What's the appropriate approach to preoperative anticoagulation? Continue the warfarin, titrate it down, stop the warfarin 5 days prior without bridging, stop it 5 days with bridging, stop it 7 days with bridging. What would you do? Let's see if you can get another 100% on this thing. Okay, you can do it. There were some questions about what do you do for preoperative anticoagulation prior to non-cardiac surgery for prosthetic valves, and Geske is going to talk about that on Tuesday, so we'll have that on a separate thing. So Michael, you got 100% and a 99%. With that, we'll go ahead and let you go then, but thank you very much.
Thank you.